Hello all. This session is continuity of our previous session, that is Introduction to Motor Learning. So I once again welcome all our viewers and our esteemed speaker, Dr. Radha Bhattad. I now request ma'am to please take the session ahead.
Thank you, Dr. Frenny, for your kind introduction. So let's begin with our today's session. As we all know, this is a continuation of our last session. So just to brief, in the last session, what we have dealt was definition of motor learning, then contents of motor learning, theories of motor learning, types of motor learning, and the stages of motor learning. So today, then we'll move ahead with today's session. So in today's session, we are going to cover is motor learning strategies, which includes development of the strategy, what strategy and how to develop that strategy, what are various types of feedback and how it is important for us. Practice, what are the various types of practice that can be used for motor learning, and principles of promoting function-induced or use-dependent recovery. So let's begin. So when we are talking about motor learning strategy, it has mainly three things that we need to look upon, which is strategy development, feedback, and practice. So when we will be moving ahead with this session, we will come to know in details about all these things. So we need to plan, and this should be tailor-made. Individual patient-wise, you need to decide what type of feedback, what type of the practice you will design for your patient. And even it is in that particular session, if you feel that this particular strategy is not working, you can immediately change your strategy to deal with. So it's that way the simple part of it. So let's begin with what does this strategy development means. So strategy development is a task that needs to be learned, should be important, desirable, and realistic to learn. So as we had seen in our last session also, and this is a very big principle of life, that if we find anything relevant, then we give our interest or we give our 100% input to that particular thing. If we think that the task or that activity is important for me, or exercise is important for me, which will help me to climb stairs, which will help me to stand, or XYZ, then only there will be, the patient will participate enthusiastically, he will be motivated to do the things. So the task or the exercise or whatever activity that you are planning for your patient should be important, it should be desirable and realistic to learn. Realistic to learn is you cannot expect something because you are well aware with your patient's impairment. You should take into account what are the impairment, what type of the medical diagnosis your patient is having, what is the prognosis of your patient, and set accordingly. The goals should be realistic, and exercise for that goal should be realistic. Next is, means whatever activity that you are planning, that is done. Next is whatever you have planned for, or whatever exercise you have planned for, it should be, you should demonstrate that particular task to the patient. It can be done by you as a therapist, or you can show him the video of previous patients, how they were doing it. Or if some other patient is also doing the same type of exercise, you can just show this is what I am expecting of you, or this is what you should be doing. So point out similarities to the other task learned. Also, this can be done if any other task or any other exercise was having some of the components of that particular thing. So in the same manner, if you are making a patient learn in standing how to move the COG anteriorly, posteriorly, so that the balance gets improved, if you want, you can correlate it with the way in sitting we did this thing, or same way now you have to lean forward. So you can relate with the activities that already the patient has learned or knows. So this will help enhance learning. So that can be done. Highlight the features of the environment critical for the task. So for an example, initially you were training for sit to stand from a specific chair or a specific height. Now, if you have changed the height of the chair, or if you have changed the surface of the chair from which now you are training your patient to do so, you can just emphasize we need to do it the same way we were doing it previously. The only thing that you need to look now is the height from which you are getting up. So maybe your efforts required will be more. Here the point to be emphasized is now as the height has decreased, you will need to put some more effort. So that is how you highlight the features of the environment. If you are training for a gate where you have put the obstacles, you just need to make your patient aware that I have placed some obstacles. Now you have to overcome that obstacles. You need not to go around, you have to overcome. So these are highlighting the features of the environment. So choose something which is important, desirable for your patient and is realistic for your patient. Demonstrate the patient and highlight the key points or the key features. If any modifications has been changed, try to correlate your exercise with the previously learned exercises or the task or the activities which is learned, so that the patient knows the similarity. It increases his or her confidence level. Plus, you have to have a strategy of guiding the movement. This guiding can be provided through your manual guidance. You can use verbal guidance or feedbacks, visual feedbacks or some other things can be used for guiding the movement SOS whenever required. Next is you need to plan which type of feedback that you are going to use and what type of the practice that you are going to use for your patient. So overall, the strategy that we need to use for our patients so that they learn the movement we need to take care of all the above points that we had discussed. Now we will be moving to the type of feedbacks that can be given during the exercise and why it needs to be given, what is the importance of giving it, and how to choose which feedback to be given at what time or for which type of patient. So coming to the feedback, see, we all know if we want to learn, if we want to grow in our life, whatever we are doing, there is a scope to improve in that particular thing. So how you will come to know there is a scope? One will be your self-analysis of the thing, and it will be a critical analysis by some other. Means you will get a feedback for that particular thing, and that is how there will be improvement. In the same manner, when we are teaching a movement to our patients or an activity to our patient, we use is the feedback. So there are two types of major feedback. One is intrinsic feedback, and the other is the extrinsic feedback. Intrinsic or inherent, we will call it as. So this is the internal mechanism of the body through which a person receives the feedback, which includes your proprioceptive system, visual system, vestibular system, and cutaneous signals. The other one is your extrinsic feedback or the augmented feedback, which is a supplementation or an add-on thing to your intrinsic feedback. For a case, for some time, if any of the sensory system is at some problem for your internal feedback, the extrinsic feedback will add on to it. But also, if there is no problem with the sensory system at all, still your external feedback will supplement your internal feedback, the internal feedback which the patient is receiving from his or her own body. So when we come to the extrinsic feedback, this feedback can be given verbally, can be given manually, or any biofeedback devices can be used for that particular purpose. So now we will be seeing the types of extrinsic feedbacks in detail. So there is various types. So one of the type is your concurrent feedback. What this concurrent means is ongoing, along with. Okay. So this type of extrinsic feed for this particular thing, when a person is performing a task, for example, if a person is doing a reaching activity, so you can give a concurrent feedback to your patient about, no, you need extend your elbow more so that you reach it. Come on, extend it. Come on, extend it. So this type of feedback while the movement or while the exercise is going on is called as concurrent feedback. And again, this concurrent feedback can be given verbally, can be given manually. You can tap, you can give a manual feedback in that particular way, or you can use some other devices if you have so. So the main thing is concurrent feedback is given while the task is being performed. That time you are giving is the concurrent feedback. So concurrent feedback is also a type of a knowledge of performance, which is called as KP. So you are giving about, the feedback is about how is the quality of movement, or what change needs to be done in the quality of movement to accomplish the goal. So that is what is your concurrent feedback. Next is your terminal feedback. So as the name itself suggests, terminal means at the end. Concurrent was during the movement. So terminal feedback is, again, it is given after the task is performed or after the exercise is performed. Again, in what ways you can give the feedback is again the same. You can give verbally, you can give using biofeedback devices. Nowadays that VRT or some other devices, they have it. Once the task is done, if you want to give knowledge of result, ki the task accomplished or not, so there will be some clapping or some bunnies jumping or something, which is a terminal feedback. Yes, you achieved your target at the end. So that is what is your terminal feedback. For terminal feedback, the knowledge of result as well as knowledge of performance both can be given. So if we are saying, yes, you did it or you achieved the target, if we are teaching reach outs for that matter, and if the patient touched the target, we are saying, yes, you had achieved. So you have touched the target, you have achieved is knowledge of result. Knowledge of performance is you had used this trick movement while achieving this. This should not be used, is knowledge of performance. It is as simple as our results. When we get our results, we are like pass or fail is knowledge of result. Task done, not done is knowledge of result. How well the task is done is knowledge of performance. So in which subject you could have done more better, or what went wrong, if this type of feedback is given, that is your knowledge of performance. So while giving terminal feedback, you can give knowledge of result also and knowledge of performance both also. So coming to the knowledge of result and knowledge of performance, which is also called as KR and KP. So majorly we have already discussed right now, both are extrinsic type of feedbacks. Knowledge of result can be only given after the movement is done, means it is part of your terminal feedback. While as knowledge of performance can be given during the movement as well as at the end. So that is your type of your both terminal feedback के फॉर्म में भी आप यूज कर सकते हो and concurrent feedback के फॉर्म में भी आप उसको यूज कर सकते हो. Next is your knowledge of result, as we had said कि goal achieved or not achieved. Knowledge of performance is how well or how accurately the goal is achieved. And we should note that both knowledge of result and knowledge of performance can be used in your terminal feedback and can be used individually also and can be used together also. So you can give your patient feedback at the end of the movement that yes, you did the movement, you have achieved your goal, but this can be done. So you are using both KR and KP in the terminal feedback. Next is immediate feedback. So what is immediate feedback? Presented immediately after the movement. So after each and every repetitions, if you are giving feedback, that is your immediate feedback. Delayed feedback is, it is given after some sets of repetition. So you can ask your patient himself or herself कि आप जब कर रहे थे, what have you noticed? How well have you done? Or how would you rate? What went wrong? And plus you can add on to what was your observation or what needs to be improved to improve the performance. But this is a delayed. It is given after some time or after some repetitions. Care should be taken if we have a long delays in giving the feedback. There will be a memory bias and it will not be that effective. So preferred immediate feedback, or if delayed also, there should not be a long gap between the feedback that you are giving. Next is your summary feedback. So this is given after set number of trials, like after every 2 trials, after every 7th trial or something, that you will be giving a feedback, which will be a summary of all together. So like delayed feedback can be given in the form of summary feedback. After one exercise was done, you have shifted your patient to some other exercise. Now you are trying to give the feedback about the previous one, or trying to relate that exercise with this exercise and trying to give the feedback for that particular thing. That is a typical delayed feedback. Summary is, you have decided that we will have 50 repetitions, but after 10 repetitions, you choose to give a feedback, is your summary feedback. Again, after 10 repetitions, you choose to give the feedback to the patient, is your summary feedback. And whatever types of feedbacks that we are learning, you can use mixed version also of the feedback. Sometimes you give immediate feedbacks, and then you see that there is great improvement in the performance. Now your patient doesn't need feedback, so you can immediately switch to summary feedback type of thing. So it will be dependent on the patient and his performance. Learning, if you see there is change in the performance, desired change in the performance, you can change your type of feedback. If you see there is no desired change in the performance, again you should give a rethought. No, I need to give more of immediate feedback to the patients, or I need to emphasize, or even whatever the method of feedback that you were using. Sometimes you will see I was giving just the verbal feedbacks and that is not working that effectively. You immediately switch with your manual feedback to the patient. So the strategies that whatever we are discussing about practice, about types of feedback, you have to mix and merge and decide it patient to patient, as well as in that particular session also what type of the thing that you would like to use. Next is the faded feedback, which I already told right now. Ki initially, every trial ke baad you are giving a feedback to your patient, but then gradually you taper down. After sometimes you give, means after 7-8 repetitions you are giving, and then after 30 repetitions you are giving, means you are just fading because your patient has really learned it in terms of the performance. And as we had said in the previous session, the performance is not equal to learning. Performance plus retention and adaptability will ultimately give you learning. Next is a bandwidth type of feedback, which is again a knowledge of result type of thing, given only when the performance deviates outside the boundary of correct performance. So this is patient is doing the activity or performing the task. If something goes wrong, then only the feedback is given. Otherwise, there's no need to give the feedback to that particular patient. Next is blocked feedback. So this where immediate feedback, terminal feedback, concurrent, all this. Next is your blocked feedback. So simple, as the name itself is having block. So you have divided a particular task into subtasks. You are training for a specific component of that subtask, and you are giving feedback for that particular thing, is your blocked feedback. For an example, during gait training, you are giving knowledge of result is presented about knee segment only on successive trials. So if you are training ki there should be no hyperextension, or if you want to give the feedback or cues for that particular thing, means you are focusing only on the knee component during mid stance of the gait, is the blocked feedback. Rest other components, if they are deviating, you are not that much bothered, because right now for this exercise, for this session, if you were focusing on that particular part, that particular component, which is also, you will see it in blocked practice also. We decide a target and we target that particular thing for that particular exercise session or for that particular exercise. Then we use this blocked feedback method. But the blocked feedback is more or less, again, the problem with that is the performance deteriorates once the knowledge of result is withdrawn. after this. So there are advantages, disadvantages of each and every one. That is the reason I said in the beginning that we need to choose it wisely, and it should be patient wise and patient's performance wise. Variable or random feedback, again, this is multiple source of feedbacks are provided. Knowledge of result is presented about different segments on successive trials. So sometimes the knee component in the gait is being given the feedback about, sometimes the hip component or the ankle component is given the feedback about. So there is no consistency. You are giving feedback when you are training, or you are giving the training, so you can decide on, or you are switching with the feedback wherever the component you are feeling is going wrong, of component or the subtask of your main task is going wrong, you give the feedback. So now how you will make a decision about the feedbacks that we had seen? There are many types of feedbacks. Now how to choose which type of the feedback is to be given to the patient? So consider the cognitive and the physical resource of the patient and the complexity of the task. First and foremost is you need to be very well aware with the higher mental functions and the sensory systems of your patient. Accordingly, you will decide on which type of, which source should be used to give the feedback. Verbal feedback आपको देना है, visual feedback आपको देना है, manual feedback आपको देना है. Plus, what are the resources that are available with you? If you have some biofeedback devices, you can choose that. If you don't have, you go with some other. So resources, what are the available resources? What is the cognitive level of your patient? If your patient has a low cognitive level, then you may need to give him verbal as well as tactile feedback, and give immediate feedback after every performance. Maybe after many sessions, you may move towards the faded feedback, but initially for many sessions, you need to focus with those things. So while deciding which type of feedback that you need to give is, cognitive level needs to be taken into consideration, resources, physical resources needs to be, plus your resources as well as physical resource of the patient, what is there that you need to take into consideration, and the complexity of the task. So if the task is a complex one, like a gait one, and if you are deciding on no, we will first focus, or when you have done your task analysis, you have found out these two are the missing components or the components which are deviating, we need to train for that. Accordingly, then you decide on, no, I will move with the block type of feedback or block type of practice, you go ahead with that particular thing. Also, which I mentioned, the intrinsic sensory system of the patients need to be taken into consideration. Also, we need to take into consideration is the stage of learning. As I said, initial cognitive stage, as we had discussed, stages of learning has three things: cognitive stage, then you have is associative stage, and then you have this autonomous stage. So if the patient is in the cognitive stage of learning, or just has, it is his or her first time or initial sessions, maybe you will require immediate feedbacks. Then you may move towards a faded feedback or some other type of feedback. So cognitive stage of learning, and there may be a stage when your patient is in moving from associative towards autonomous stage, then you may not give feedbacks also. Maybe it is not required then, because the patient has mastered that particular activity. So these are the things importantly that needs to be taken into account before deciding on which type of the feedback you are going to use for your patient. Next component was, as we had seen, was strategy development, which was having some components. Next was your feedback types. Next is your practice types. So now what type of practice you would use, or how you would design your session so that you get motor learning, or you get your patient learn that particular activity or gets improvement in that particular activity. So practice has a major influence on learning. We had seen it number of repetitions, number of practice that we do, more is the learning. So increased practice, increased learning. Initially large and rapid movements, and then you can move towards refining it or a smaller improvements. Whatever type of practice, whatever type of feedback, whatever type of things that you decide, the most important thing is patient should be involved in goal setting. What are the expectations of your patients need to be considered first. When a patient comes, what he wants from you, what are his expectations or what he wants to achieve, how many of them are realistic, how would you progress towards it, what sessions you will design for that patient. So you need to involve patient caregivers for the session. And for goal setting, it is you and the patient who needs to decide onto the goals. When a patient is involved in the goal setting, as we had seen when we were dealing with the strategy development, it should be desirable. If the activity is desirable, patient and the therapist are on the same goal, then it will motivate and the patient will have 100% commitment for the exercise session. Oh, okay, fine. After doing this, I am going to learn stair climbing, which will reduce my dependency on somebody else. So he himself is a part of the treatment now. His commitment towards the treatment will be highest. Next is, what are the factors that can affect practice? Okay, we have taken into consideration everything. Still, there are factors that can affect your practice or that can affect your repetitions or the session of the exercise. Patient motivation. So this can be a bit overcome, like as we had discussed just now. If we take patient into goal formation, there will be more chances of his commitment. So he will be more motivated. But patient's motivation does matter a lot. Patient's attention span, his cognitive level, his concentration, his endurance, type of the task that you are choosing. That's the reason we decided the first thing was it should be desirable, realistic thing for the patient. Sessions allotted at hospitals. If it is required, there should be lot many sessions. Lot many sessions are being given? Is the manpower that efficient, and that is the manpower available for that many sessions? So there are lot many things that can affect the practice. Sessions allotted at the hospitals, availability of the services, and the payment. So this all can affect the practice of the patient. Factors that can affect practice at home, because sometimes it happens that we have few of the sessions at the hospitals, or one session at the hospital, one session at patient's own home. So what are the factors that can affect his home sessions? Same motivation of the patient as well as the caregivers or the family members, what type of family support he is getting, and is the environment suitable? Because in the hospital you have all the things that you want to give the exercises using any equipments or any sort of the things that you have chosen for. So at home, is the environment suitable? Are the things available or not? So all these factors will definitely affect the type of the amount of the practice that a patient receives. Some factors are modifiable, some factors are not modifiable. So we need to take into care what are the factors that are affecting which can be modified. If can be modified, do the modifications. If cannot be modified, we leave it in that particular manner and try to revise some other part of the things so that there is ultimate benefit of our patients. So coming to the types of practice or the parameters, majorly first is your type of practice. Next is practice sequence. What type of sequencing are you going to use in your session or for that particular exercise will be a factor. In what order you will be doing is again one more thing that will that has a effect on the types of practice, or basically they are the parameters. So sequencing kaise rahega, what will be the order of practice will be are the parameters of your practice thing, and what are the strategies that you can use for practice. So the first is There are two types of practice. One is masked practice and one is distributed practice. So as you see, masked practice here, the number of repetitions or number of the practice or the number of sessions that you give to your patients are more than the rest interval. On the contrary, in your distributed practice, you are distributing the practice. So here the practice and the rest intervals can be equal, or the rest interval can be more than the practice sessions. So here when we are talking about the practice, it can be your sessions, it can be number of repetitions for that particular thing, which we will see in parameters in more detail. So in masked practice, fatigue can decrease the performance, as here our practice is more as compared to the rest. So chances of fatigue or risk of injury is more in your masked practice, while as fatigue and risk of injury can be well taken care in your distributed practice. Masked practice is preferred for the patients with adequate endurance, who have good attention and concentration, while distributed practice is preferred for the patients who have low endurance, low motivation, short attention span, motor planning deficits, complex task training, if you want to go with task with higher energy requirements. So in such conditions or such time, you should prefer using distributed practice over the masked practice. Also, like if you are in the final stage of rehabs, masked practice, more practice as compared to the rest interval is the preferred one. While if you are in the initial stage of rehabilitation and if your patient has anything of the above that we have right now discussed, you can move with your distributed practice. So majorly masked practice is more as compared to the rest interval. Distributed practice is equal to or less than the rest intervals. Next is your block practice versus random practice. Now, when we are talking about this block practice versus random, here in block, all the trials of one task are done together, are interrupted by the practice on any other task. Example, bed to wheelchair transfer is mastered, then wheelchair to the toilet training is given. So patient's goal was to achieve, I should be able to move from my wheelchair to toilet and do the stuff. So first you are just giving him the training of from bed to wheelchair. Next, once he achieves mastery in this, then you train for wheelchair to toilet, and then vice versa. So that will be your block practice. So out of the bigger goal, you have chosen a smaller goal, or you have decided on sub goals of your main tasks, and then you are focusing on one particular thing and you are just giving practice for that particular thing. So that will be your block practice. Random practice is you are giving bed to wheelchair, then wheelchair to toilet, and together when you are mixing it, no, now go from this to this, now go from this to this. So, or sometimes here to here, coming back 3-4 repetitions of wheelchair to toilet and 3-4 repetitions of wheelchair to bed and bed to wheelchair. So you are mixing, you are targeting the whole major goal all together. Block practice has it is superior, initial performance are more. Random practice shows superior long-term effects in terms of retention because the whole task is done together. Low contextual interference is there with your block practice, and with random you can give high contextual interference, like simple again with the sit to stand examples. With varying chair heights you are trying to focus on, and here you can fix the chair height and focus on the repetitions. So there you are giving high contextual interference, means varying task demands is what you are making your patient exposed to, while as in the block you are not. So you are waiting for this to be mastered and then moving to something else. So block practice, it is preferred for the patients with traumatic brain injury who have profound cognitive or behavioral deficit or advanced stage of Parkinson's disease. While as random practice is preferred with good cognition in who are having good cognitive level SCI patients, spinal cord injury patients, you can move towards your random practice. See, whatever we are discussing right now are not the thumb rules. It can be dependent on patient to patient, his understanding level, his performance level, his motivation level, his physical level, what sort of impairment the patient is having accordingly. So initially that what we had seen was your masked and main two types of your practice, which were your masked practice and the distributed practice. Next was the sequence in which we are going to practice. Accordingly that we had seen this blocked practice and the random practice. Now again, order, in which order the practice has been given to a patient. Accordingly, we have three types: blocked practice, serial practice, and the random practice. So this is blocked order, serial order, or random order. So blocked order is, for example, 3 trials of task 1, 3 trials of task 2, 3 trials of task 3. It is a set protocol. You will come, you will do this many repetitions for this particular thing, then you will do this many repetitions for this particular thing, then you will do this many repetitions for this particular thing. So you have formed a blocks. Serial order: 1 this, 2 this, 3 this. So for example, when we were talking about bed to toilet transfer things using wheelchair, so with block practice you can have is 50 repetitions of bed to wheelchair, then there will be 50 repetitions of wheelchair to toilet. So that will be blocked. Serial, it can be wheelchair to bed to wheelchair, wheelchair to this. Again, bed to wheelchair, wheelchair to this. So it will be serial order. Random order can be, again, you are doing like bed to wheelchair, wheelchair to bed, wheelchair to bed for 2-3 times, and then all of a sudden you start with the next component, then again you switch to the first component. So it is random order. So this type is called as, depending on the parameter here is order, what type of order you are choosing for your patient to practice. So blocked order does not require that good memory for retrieval, because the patient is doing that particular task for lot many repetitions. So it does not require good memory for retrieval. While a serial order, it requires good memory, because A task is done, then the B is done, then the C is done, then the D is done, then again the A is done. So you have to have a good memory recall. The patient needs to have a good memory recall. What were the components that I was taking care while doing the task A? What were the components that I was taking care while doing the task B? And so forth. And the same applies with the random order. But if you see in terms of retention, the best retention is in random order. Blocked order, you don't have that much good amount of retention. Again, stage of learning you need to take care while deciding on, and the other factors that we discussed. Accordingly, we can decide on which order parameter we need to choose while giving the exercise to our patient. Again, the progression can be made from blocked practice to serial to random order thing. So the last one with this is the strategy. Practice key strategies. What are the strategies that can be used while practicing? So this is your mental practice. In this mental practice, the patient mentally imagine or mentally recalls the steps of the task, or visualizes the steps of the task to be done. So you can even add mental plus physical practice is more over only physical practice alone. So your concepts of mental imaginary, motor imaginary, and if this should be chosen for the patients whom you know, first of all, they should be cognitively well so that they can retrieve or visualize or imagine the tasks, but their cognitive is well, but they don't have that much of endurance, or they don't have that much of effort. So here you can mix. You can have your mental practice plus physical practice. Even before performing the task, you can have the mental practice done, and then you ask the patient to physically do the task. So that is one sort of thing that you can use. You need to ensure that your patient has understood the task correctly. Patient verbalizes all the steps being rehearsed and can ensure that this occurs. And as I said, it is contraindicated or it should not be used for the patient who have high level of cognitive problem or communication or perceptual deficits. Here you cannot go with this particular type of strategy. Then is part or the whole practice. So part or whole practice is complex task or a main goal is divided or broken into subtasks or a small components of that particular tasks. So you can have the practice of the whole task or you can have a practice of that part task. For example, if when we see sit to stand movement, you do the movement analysis, you find out what are the missing components of the particular activity. If there are two missing components and you want to focus, first you focus on one missing component, then you focus for exercises with the second missing component, then you ask your patient to do the whole thing together. So you are moving from part practice towards the whole practice of that particular thing. Next is transfer training or transfer of learning. So again, the more the variety that you will give to your patient, the more will be transfer of training or transfer of learning. As we had seen, one of the major factor, one of the major thing with which we see is the movement learned or not was adaptability, which was our third component into the measure. So if we want, there should be adaptability, there should be transfer of training. A patient who is performing well at your exercise sessions should be well performer at the home or should be well performer in the community. You want this transfer of training to be there. So how we can achieve this is by providing variety, simulating environments or simulating the subtasks or the task that we require or that is in relation to the patient's own life. So by that we can have our transfer of training. Next is, so when you are designing, so these are all the things that you can use, any of these strategies that you can use, or any one, any two, combine, or all, whatever you wish to. So you can have your mental practice plus physical practice. You can take care of the environmental variations that you want to give to your patients. Next is practice, or you can divide part practice, or you can choose part and whole practice together. Next is practice of the lead up task. So this lead up task are your sister task or your sub task, which will lead to the final task or which will guide the patient towards the final task. For example, first we are going with standing in the parallel bars with support, then without support, and then standing without the parallel bar. So what we are doing was, standing was our main task. Standing without support was what the goal we were trying to achieve with our patients. So initially what we had chosen is in parallel bar with support. So this was a lead up towards or a guiding task for our main goal of the task. So this is how we can have practice of lead up task also. So as we had seen with what are the strategies for designing a session or for a practice, what things we need to take into consideration, what are the various types of feedback, what are the various types of practices, how to choose which one can be chosen, what are the advantage of one over the other. So now finally what we are going to see is the principles of promoting function induced or use dependent recovery. What are the principles? If we are saying, if we want to promote function induced recovery or use dependent recovery, so what are the principles? There are few principles which we are going which we will be seeing in brief. So focus on active practice of motor skills. So it is use it or lose it. These are your experience dependent neuroplasticity principles. So if it is used, then it is been taken care. If it is not used, you will lose it. So there should be active practice of the motor skills. Engage patients in active practice of a specific goal directed activities. You must have heard this very often. People say, try to use whatever skills you have. If you will not, it will go. So it is that simple. Use it or lose it. If you will practice, you can achieve it. If you won't practice, you will lose it. Even you will lose those things that were helpful for achieving that particular task. Next is repetition is important. Lots of repetitions is required, as we all know, throughout our education, throughout our life, whatever we are doing, we need lot of practice, lot of repetition to have mastery in some particular things. So repetition is important if we want recovery. Intensity is important. Something given with less intensity, less repetition, less sessions, you may not get that recovery. If you feel this is the acute stage, timing, which we will be coming towards subacute stage, we know the chances of, the evidence says post stroke, the chances of recovery for first 6 months are more. After 6 months, the chances of recoveries are less. No chances is not there, less chances is there. So this particular time durations need to be targeted more. There should be intense exercise during this particular time period. So accordingly, that is the component that we need to take care. Repetition is important. Intensity of exercise is important. Doing exercise is important, which is the first one. Use it or lose it. Next is focus on modifying motor skills. As we were talking about adaptability, as we were talking about transfer of training, use it, shape it to the patient's ability. So the first thing that we had seen was it should be important, desirable, and realistic. So use it, shape it, design your exercise in such way that it shapes the patient's ability and his requirement and his expectation. Use it, shape it to the patient's ability. Continually challenge the patient movement capacity with acquisitions of new skill, progressing, modifying skills to achieve the functional outcomes. Is if you have seen that your patient has achieved this, now move towards other. If you want variations in this, make the exercise more challenging so that you achieve your goal, whatever you and the patient has finalized to achieve. Enhance selection of behavioral important stimuli, create the best possible environment for learning. So as we had seen, whatever the feedback, whatever type of feedback, and the thing with which you were giving the feedback, verbal, auditory, visual, whatever the thing was, and the environment, motivated environment. So environment influences learning. So enhance the selection of the behavioral important stimuli. What will give you the best result from your patient? Try to create that environment. Try to choose those strategies. Try to choose those things. Enhance attention and the feedback. Again, rewards, feedbacks, enhances learning. So you need to enhance attention. Try to make exercise engaging. Try to have your exercise sessions some variety of things. Reduce monotonous things to be done by them. So more the good the environment, it will increase the attention. It will make patient more engaging, more dedicated towards the exercise, and your feedbacks, your rewards will enhance their learning. Target goal directed skills. So if at least you should be able to have this exercise, this goal, this exercise, this goal is what we are going to achieve. In that particular exercise also, if you reach till here, the goal is achieved. So when you have a goal, when a patient knows the goal is achieved, the thing that we were required to do, it automatically enhances his next performance. It motivates him because he is knowing that there is a reward. I mean, I have achieved it, that there's a feeling of that particular goal attainment. So the things should be goal directed skills. Timing is important, which we had already just now discussed about it. Key timing very early training may be detrimental, or extraneous training in the initial stage can demotivate if you have designed something which the patient cannot do at that particular time, and you are expecting the things from, because you were not realistic in that particular exercise designing, and that will demotivate because the patient will feel I am not able to achieve it. So you should be very realistic and timing should be taken care. Again, age has a effect on it. Youngs have fast and demonstrable recovery, olders have slower and less demonstrable recovery. So these are the sets of principles that we need to take care while we design the exercise, or we design the session, or we design the treatment protocol for our patients, so that we achieve the best possible motor learning in our patients, so that they learn the movement, they learn the action, they learn the task, and they are more functionally independent. Hope the session has just touched and the all parts of your concepts which are required for motor learning, and is seen to be helpful for you all while you design your exercise sessions or the sessions for your patient, or design the exercises. Thank you.
Thank you, ma'am. Thank you for providing insights of a very important topic from a physiotherapist point of view. And I'm sure this section of yours is going to help many physiotherapists in deciding their treatment and planning their treatment. I would also like to thank our principal, Dr. Apoor Shimpi, for giving us this opportunity. Special thanks to the entire team of Physio TV. And we are also grateful for providing the technical support. So thank you to the technical team as well. So here I, Dr. Franny Nathani, sign off for the session. Thank you.
Thank you.